Okay, let's dive into the clinical profile of elinzanetant. It's a newly approved non-hormonal therapy for vasomotor symptoms, and we're going to break it all down. Its novel mechanism, the key phase 3 data, and really where it's going to fit into our day-to-day treatment plans. So we all have these patients, right? They're dealing with moderate to severe vasomotor symptoms, but hormone therapy just isn't an option. I'm talking about that significant treatment gap, especially for our patients with a history of breast cancer. And that's precisely the challenge elinzanetan was developed to tackle.
And it did. In late 2025, elinzanetant, which goes by the brand name Lynkuet, got the green light from the FDA. This gives us a really critical non-hormonal tool for women who either have contraindications to estrogen or, frankly, just strongly prefer to avoid it.
First, let's just quickly frame this unmet need, because it's so important to remember that VMS is way more than just a quality of life issue. You know, persistent vasomotor symptoms are not benign at all. They're independently linked to some pretty significant long-term health risks. We're talking insomnia, a real increase in cardiovascular events, and even accelerated bone loss. It really does impact multiple organ systems. So, how exactly does elinzanetant work to fix this? Well, its mechanism is what truly sets it apart from the other non-hormonal options out there.
It all comes down to the neurokinin pathway in the brain's thermoregulatory center. See, during menopause, as estrogen levels drop, these neurokinin receptors become overactive. This messes with temperature control and ultimately is what pulls the trigger on a hot flash.
And here is the key differentiator. Unlike elinzanetant, which only targets the NK3 receptor, elinzanetant is what we call a dual antagonist. It blocks both NK1 and NK3. The hypothesis is that this dual blockade is the secret sauce that contributes to its distinct clinical effects, especially on sleep. But does this cool dual mechanism actually translate into clinical benefit for our patients? Well, the data from the pivotal OASIS trial program is pretty darn compelling.
And this is so crucial. The OASIS-4 study gives us that high-quality evidence we've been needing for a particularly tough-to-treat group, women with a history of breast cancer who are on active adjuvant therapy like tamoxifen or aromatase inhibitors.
The primary endpoint showed a really rapid effect. I mean, at just 4 weeks, women taking elinzanetant had a statistically significant reduction of 6 fewer moderate to severe hot flashes per day compared to placebo. That's fast.
And this wasn't just a flash in the pan. The effect was sustained and actually got even better over time. By the 12-week mark, that number improved to 8 fewer hot flashes a day, showing a really durable response. Now, to put this into perspective, estrogen is still our gold standard, right? It gives us roughly a 75% reduction, but elinzanetant comes in with a powerful 67% reduction. For patients who absolutely cannot take hormones, that is a very, very clinically meaningful improvement. But here's where it gets really interesting. Beyond just the hot flashes, the data showed a significant direct effect on sleep. A mediation analysis found that over half, 54% of the improvement in sleep disturbance was a primary effect of the drug itself. It wasn't just because of fewer night sweats. This points to a direct impact on sleep architecture. And this unique benefit is exactly what many experts, like Dr. Lauren Streecher here, are really highlighting. The clear improvements in sleep and overall quality of life might be what really sets this drug apart in the non-hormonal class. All right, let's switch gears to the practical stuff. Safety, what monitoring you have to do, and how to handle dosing adjustments.
Overall, the safety profile was pretty manageable. The most common things we saw were CNS-related, headache, fatigue, dizziness, and they were generally reported as mild to moderate and seemed to get better over time.
Now, listen up, because this is a critical point for prescribing. The label includes a mandate for hepatic monitoring. You must get baseline LFTs before you start. If those transaminases are already up at twice the upper limit of normal, do not start therapy. Then, a follow-up check is required at 3 months to monitor for any changes. Elinzanetant is metabolized by CYP3A4, so you've really got to think about drug-drug interactions. If your patient is on a strong inhibitor or inducer, you should avoid using them together entirely. And with moderate CYP3A4 inhibitors, you have to cut the dose in half, from the standard 120 milligrams down to 60 milligrams once a day.
So let's put all this together. Where does this new agent actually fit into your clinical practice?
Well, elinzanetan's primary role is pretty clear. It's an ideal option for women with moderate to severe VMS who either have a real contraindication to hormone therapy, like our survivors of hormone-sensitive cancers, or for that large group of women who, for their own reasons, just prefer a non-hormonal treatment.
So, to wrap it all up, elinzanetant is a novel dual NK1/NK3 antagonist. It effectively treats both hot flashes and sleep disturbances. It has proven efficacy in that challenging breast cancer survivor population, and you gotta remember, it requires that baseline and 3-month hepatic monitoring. The approval of elinzanetant is another huge step forward for us. It lets us be more nuanced, more individualized in how we manage menopause. It moves us further away from a one-size-fits-all model and gets us closer to a future of truly personalized care for our patients.